So recognizing that we've had a long conversation. However, I do want to make sure that we are also touching on not just the problem and characterizing the problem, but what are the solutions? For all of us, I do think it's important for us to think about who is the person where is it that I'm going straight to CPAP or should I be sending them to a different route? Is it going to be that I'm utilizing a medication or bariatric surgery or ENT surgery or OMFS? Is it that I'm doing it at the same time? I think where we're at right now is trying to move away from the singular solution and really saying what is the polytherapy that may be needed? What is the stepwise approach that may be appropriate? And how do we determine whether or not this is a successful intervention or not? And I always like to guard that because what I've learned in working with residents is that they very much frequently are being taught that medicine is binary, that you either succeed or you fail, because that's how we've been trained our entire life, is that there is a multiple choice answer and there's only a singular response, and you either get it right or you get it wrong. And many times we can see an incomplete response, which is not a failed response. It is that the person is telling you, I'm getting better. I either may need more time on that therapy or I may need something else to better support it. So from clinical practicality, Atul and Reena, what are some pearls that you would give of how are you negotiating with your patient and who's sitting in front of you? What might be the right first step? The person who's like, I'll do whatever you say, versus the person who's like, don't even talk to me about a mask because there ain't no way that I'm going to put that on, or I have significant claustrophobia. I can't even consider it. What are some of your approaches?
Yeah, I can address some of that at least. So, one point to emphasize in the Surmount OSA study that was in New England Journal last year, we compared tirzepatide to placebo in patients not on CPAP. We compared tirzepatide to placebo in patients on CPAP. So, there was no direct comparison to CPAP. So, to me, it's not therapies in competition. To me, it's adjunctive
Agreed.
therapies.
Agreed.
So, for example, Chirinos from Penn had the paper on do you treat either obesity or sleep apnea or both? You'd be a fool to say anything other than both, which is what Chirinos found if you look at lipids and glucose and blood pressure and all that. In aggregate, treating both. Similarly, if somebody says, do you treat either diabetes or hypertension? You'd be a fool to say anything other than both. And so I think that's where we're at. And so, in terms of, to me, it's not a negotiation, it's not therapies in competition. I talk to patients about different treatment options. Often for insurance reasons, we have to start with CPAP before other things will be approved. But if I'm treating sleep apnea, that doesn't mean I shouldn't treat their obesity as well. I treat both. And then there are alternative therapies. So if they fail CPAP, then we talk about surgery or we talk about oral appliances. But there are also adjunctive therapies, right? So somebody gets a partial response with an oral appliance, then positional therapy or a little bit of weight loss, or these things can be helpful as well. So I look at it as an iterative process, not therapies in competition, but how best to get this patient feeling better and get their cardiovascular risk lower.
Now let's just talk about that practically, right? Because that's beautifully stated. But let's talk about the fact that the average clinician is going to start you on a CPAP. I'll see you back in 3 months. Then I see you in 6 months. Then it's a year, right? How do we enable that communication, right? Because we can't, again, put it all back on just the sleep clinic or the sleep provider. It is how do we share this responsibility? How do we share this journey to wellness? How do we practically implement that? What is the words that the clinician who's listening to us right now should be saying to the patient who goes, I want you on CPAP. I can look in this cloud to see what your adherence is. These are things I want you to look at. If we get to this point, that means good. We're doing the right thing. If we're not seeing that, we need to navigate away, and this is what that next step is going to look like. Is it that we're preparing them from day one of this is what the next step is, so they know that if they struggle, there's still other opportunity? Or is there something else? Because I can tell you, I have a very dear friend, and their significant other has had their second ablation for AFib, has significant OSA, couldn't tolerate a CPAP, and believed that there weren't other options for treatment. And meanwhile, is having progressive deterioration of their AFib, right? And for me, I was just like, oh no, there's so much we can do. And looked at that as a call to action for the treatment of their AFib, not for their treatment of their OSA alone, but really looking at it as a treatment for their AFib. So what if I, you guys know, my goal is always for if someone's watching something that I'm a part of, I want them to walk away with new tools to put into their practice, not just to go, that was really interesting about those endotypes. I have no idea what they were talking about. What is the ability for someone who's listening to this or watching this right now that they can start taking whether it's smart phrases to put in their epic or some taglines to be able to provide in their counseling that they can use. And Reena, I'll throw that to you first to see what your thoughts are.
Oh, that's great. I think, I mean, the way I think to most successfully approach it is, I mean, it's a partnership, an engaged partnership surrounded, with an informed discussion, not just, okay, this is the diagnosis, now this is the singular treatment. We now are, at a point in time where have the ability to offer many different types of therapies to our patients. So I think it's an informed discussion where the treatment options are presented to the patient. The education is provided in terms of, hey, these are the results of your sleep study. These are your symptoms. This is how it's all tied together. These are the reasons why it's important to treat. And I think patient preference, as you're doing that, really emerges during the discussion is essential, to take into consideration. And because, I mean, if there's not buy-in and if there's not receptivity to a certain approach, then you're not setting the situation up for success. And I think, as these discussions are being had and the follow-up, as you said, is occurring, I think there are opportunities for us to do better in terms of, tracking data continuously and using that even as a mechanism for continued engagement as during that follow-up period. Because I mean, there's this, typical 3 months, 6 months, but are there opportunities to really especially for patients that really love data as well. And we know that, there's such accessibility to all of this technology that allows people to track data. Especially my patients who are engineers who love to look at things. I mean, and it's a nice way to kind of connect and say, okay, well, looks like we're headed the right direction. And if we're not, that's okay. Let's regroup and let's see what are our options. And then what are you, tracking, physiology, symptoms, how people are, feeling in their day-to-day activities, their social interactions, their performance at work. And then of course, we have data, in terms of, and then also, blood pressure, and then data on hard clinical outcomes, of course, is what helps to kind of shape the discussion and conversation as well.
Yeah, what I'm hearing you say is first starting with some really good education of this is what obstructive sleep apnea looks like in you. This is what I've heard you describe, the impact on your sleep, on your wakefulness, on your sexual function, on your relationships, on XYZ. You also have these other disorders that it may be impacting. So what would success look like for you? This is my thoughts. What are your thoughts? So now we have this is the end in mind, right? This is the golden goose. The next that I heard you say is you give a comprehensive handout. These are all of the solutions that are available for the treatment of obstructive sleep apnea. Clearly, we're not going to apply all of these to you today, or it may not be relevant. However, it's important for you to be aware of these because we're starting here. And this is what we're expecting success to look like over the course of the next however long. And the final piece is saying, how are we measuring all of these success measures? So there are the subjective and then the objective, and it may include where wearable, right? That is going to be giving you some of that measure, as well as those hard numbers of I'm taking your blood pressure, or I'm getting some labs, or I see that your weight is reducing. And the reason I think it's important to start with all that is because each individual who comes to us comes for a different reason. One is coming because they're no longer sleeping in bed with their significant other. The other is coming because they think they have Alzheimer's or a dementing process because they cannot attend. And then another one comes because they had a near miss motor vehicle accident. Those are three different outcomes. So one wants safety, one wants sex, and one wants to be able to make sure that they stay sane. And so with that stated, we can't use a one size fits all approach of your AHI improved. So I think that those are really great considerations there. Azizi, did you have something else you wanted to add?
I mean, I think Atul had his hand up, but I think the one thing that I wanted to underscore is, I think what we're describing is what it means to be therapeutic, right? That it's really personalizing what matters to patients, but also to ensure that we serve as the best companion alongside this journey with our patients. And we've done this. We've done some clinical trials. We currently have a few clinical trials where we are providing, not just a digital, solution in terms of, we've created this, I think elegant or elaborate, some people may think, decision tree that provides information to patients to show them exactly what the next steps are. And what we've done is we've used this technique called idiographic profiling, whereby we understand what the barriers and facilitators are psychologically to help people to determine, is it social support? Is it health literacy? And from there, we have created these, text messages that provides that level of support. The reason why I'm highlighting that is because I think what all of us are saying is, I think when it comes to adherence, particularly along the patient journey, that engagement and points of contact are critical. Many patients are extremely scared. And we've done many qualitative studies that we've published where you get in this diagnosis and they're like, is it serious? And then when you connect it and you show them that it can have unfortunate consequences, then it will grip them. But then the treatment in of itself may be this behavioral device-based treatment. And then they're like, okay, how does that impact me? I think providing more therapeutic approaches, points of contact, we have counselors that we provide as extensions to their traditional care. We found that to be, I believe, very impactful in a positive direction for patients, because those first 4 weeks are so critical for adherence and particularly acceptance of treatments. And so we've found that to be, quite impactful as well. I think where we can go, Anne Marie, and I'm sure you're going to talk about this, is how is it that with the advent of AI, how is it that we can establish a greater thought therapeutic partner along this journey that can provide not just education, but better understand how you wearing the device tonight, how that can impact, either patient, reported outcomes the next day, that can significantly help with that patient therapeutic journey.
Definitely. Atul, go ahead.
Yeah, a couple points, if I may, just to follow up on what my colleagues have said here. One is, I think patient preferences and patient-reported outcomes, I think those things are important. There's another angle, though, and that is, you could give people a provigil with sleep apnea and they might feel better, but there is an angle that major hypoxia and cardiovascular risk and these things are important as well. And so patient preferences are important, but they can't be the only driver. The other point there is
Absolutely.
sometimes we ignore the underlying cause of disease. So I'm a pulmonologist. If I had a heavy smoker with COPD, I could give them bronchodilators and they might feel better, but not addressing the smoking would be bad medicine. I think in some cases, I was guilty of this myself. People came in with severe obesity and we put a Band-Aid on the problem with CPAP. We didn't address the underlying cause, which in many cases was obesity. I think there is a patient preference angle, but there's also just being a good doctor angle as well. Two other points there. One is we published something in Journal of Clinical Sleep Medicine a few years ago about why do we ignore the chief complaint sometimes. People come in with snoring. We do a sleep test and it's okay, and you run along, you're fine. We never do that in pulmonary. If somebody has shortness of breath, you don't do a pulmonary function test saying, well, your PFTs are fine and run along, you're not short of breath. You don't argue with patients about their symptoms. And so snoring is one of those where we do a test, say you're fine and run along, and we don't treat the underlying chief complaint. I had a very close personal friend of mine yell at me saying, she was diagnosed with mild sleep apnea, but she got on treatment and it changed her life. She was back in bed with her husband. She was able to drive because she wasn't falling asleep at the wheel. She was able to function much better at work. And she said, I didn't have mild sleep apnea. She said, it's not for you to decide. And that designation or that label, mild sleep apnea, is something we decide as doctors. There is a patient angle on that as well. So I think there is treating the whole patient is an important component of this. Ignoring the chief complaint is problematic. Ignoring the underlying cause is also problematic.
Yeah. And I think of what I've heard you say is actually we just need to bridge the gap in communication. So even though the person may have come in with snoring and sleep complaints and they're morbidly obese, treating the thing that you feel like is in your lane, of course, but also helping the individual understand why you want to address the obesity, not because you are fat shaming, not because you want to stigmatize, but because you're relating that to a contribution that is going to modify the disease that they're experiencing. This is an ironic conversation because it's the same thing we are trying to do with our peers in other areas of medicine is say it's not that I want you to pay attention to sleep for the sake of sleep, but really because how sleep and circadian health modifies your lived experience. Reena, I know that you do a lot of work in obviously in research, but you also serve as the editor of the Blue Journal and have really gone great lengths to really trying to improve awareness around some of the topics that we covered today, as well as establishing other call to actions. And I think that you currently have out a request for the journal in order to enhance, again, increasing amount of enduring materials to really support the communication around this. Would you be able to share a little bit about that, about the Blue Journal and about that effort?
Yeah, thanks so much. So the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, actually, is putting out, as you said, a request for manuscripts, and this is the inaugural, the first time that the journal is actually focusing on sleep. So this is a really incredible opportunity for our field and for our researchers and scientists to contribute, given that we are in a time where it's really exciting. I mean, as we discuss the endotypes, as we discuss these new approaches to screening and treatments and pharmacologics that are now available and or becoming available in terms in our treatment paradigm. I think that there's a lot of great things going on that could be highlighted, and so just want to encourage individuals who have important work to feel free to contribute.
Wonderful. Well, it's hard to believe that we've spent so much time already together this morning. Really, this was probably one of my most favorite conversations around obstructive sleep apnea that I've had. And that's coming from a person who's more of a hypersomnolence person. Not that I ever disregard sleep apnea. Atul and I have a lot of fun getting to chat about that. And I think that's how he and I became BFFs to begin with. He's pretty shocked that I knew as much as I did around sleep apnea and published literature. And so with that stated, I do want to thank you all. This was an absolutely tremendous conversation. I think it was incredibly enlightening, and it really did cover not only the depths of obstructive sleep apnea, but also the extent of how do we actually start in the community, bring it into the healthcare system, and go back the other way. And for me, this really is what I think healthcare transformation looks like. And I'm excited to be able to have this type of conversation and really appreciate your contributions today.